Great. Well, thank you, Heidi, for your invitation to come and speak. And as I said, I'm very happy to make it as informal as you like, and stop if there are things you want to clarify as we go along. So I'm going to be talking this morning about molecular radiotherapy. So this is really very much an emerging field at the moment. So it's treatment that we've given for many, many years in a very limited number of areas. And at the moment, it's very much a growing field, which hence the title for the talk, really. So to have a look at what we've done in the past, what we're doing now, but also particularly to look at research areas at the moment and the promise that these sorts of treatment techniques have moving forward into the future. So just to give a quick outline of the things I'm going to cover. First of all, just to give a definition of what we mean by molecular radiotherapy, talk a little bit about the physics that you need to understand to give these treatments, a bit of information about the sort of practicalities and how we coordinate these sorts of treatments, the sort of stuff that are involved in giving them, and radiation protection issues, which are very important with these treatments because we actually make the patient radioactive for a few days. Then to look at what the current clinical applications are, and then to finish off by looking at some research that we're involved in at the moment, moving things forward. So molecular radiotherapy can be defined as the delivery of radiation to malignant tissue via the interaction of a radiopharmaceutical with molecular sites and receptors. Now, I've put malignant in brackets there because, in fact, there are one or two benign conditions that we use this sort of treatment for. Probably the most common of those is benign thyroid disease. So we use radioiodine to treat overactive thyroid tissue. But the vast majority of applications are in malignant tumours. And it's basically making use of a molecule that has a particular affinity to the tumour so that you can target high doses of radiation internally to the tumour. Rather than with external beam radiotherapy, where it's obviously a machine outside that's switched on delivering the radiation, this is something that we actually put into the patient that delivers internal radiation. And there are a number of routes by which we can give the treatment. Sometimes it's a capsule to swallow, sometimes it's given intravenously, and sometimes it's selectively inserted into a particular part of the body. So, for example, if we're treating liver metastases, for example, sometimes we actually put a catheter into the hepatic artery and deliver the treatment straight into the liver that way. So you'll see as we go along the variety of different ways of giving the treatment. So just talk a little bit about the physics. You'll be aware that when radioactive isotopes decay, there are a number of different sorts of emissions that they can release. And it's important to have some understanding of what sort of particles or emissions are being given out by any particular isotope, because that has implications for how it's going to work therapeutically, but also implications for radiation protection and risk to other people. So the first sort of particles are alpha particles. So these are quite heavy particles made up of 2 neutrons and 2 protons. They're heavy and charged, and they dump all of their energy over a very short distance. So they're not very penetrating at all. So basically, once this stuff is in the patient is no risk to anybody else because the alpha particles can't actually get outside of the body. When they've targeted the tumour, that's good because it dumps all the energy actually in the tumour. But if you get the thing in the wrong place and it deposits energy in the wrong place, it can cause nasty side effects. So, for example, if you had an extravasation, then you could cause skin necrosis. So you just have to be a little bit careful with these things. The second type of emission is beta particles. So these effectively are electrons. So they're a lower mass, but they still are charged. Just one negative charge. They have a slightly longer range than alpha particles, but because they're smaller, they deposit less energy. And they also can produce secondary X-rays as part of the process of them being dissipated. That's known as Bremsstrahlung, and that's actually quite useful because the beta particles themselves won't get out of the patient, but the Bremsstrahlung X-rays will, so that allows us to do scans to detect where the stuff's gone, so you can actually see where in the body the therapy has got to. Whereas with alpha particles, there is no external trace at all, so you don't know where it's gone. So the final thing is gamma rays. So a gamma ray is basically the isotope equivalent of an X-ray delivered by a linear accelerator. It's a high-energy photon that's emitted from the nucleus during the decay process. It's not charged, it doesn't have any mass, and it's very penetrating. So these are the things that cause real problems from a radiation protection point of view because they actually get out of the patient. Whilst that's a problem in terms of exposing other people, it's actually quite useful again because you can detect the gamma rays using a gamma camera and see where the treatment's gone and make sure it's targeted the areas that you want it to. So this slide just summarises the differences between the different emissions, particularly in terms of penetrating distance and what they can get through. So you see alpha particles and beta particles don't get very far at all and certainly stop by a thin layer of plastic. But gamma and X-rays travel much further. The other thing that's really important to understand when you're giving a patient an isotope is the half-life of the isotope. So this is essentially the time that it takes for the activity to fall by a half. This is very variable between different isotopes, but obviously has significant implications for how much radiation you're exposing the patient to. An isotope with a short half-life is going to be gone very quickly, whereas something with a long half-life is going to sit there and continue to irradiate the patient for a long period of time. So typically the isotopes we use have half-lives of a few days. So the most common treatment we give, I-131, the half-life's about 8 days, which is useful. So it's long enough that there's a useful exposure, but it's not so long that it doesn't clear within 2 or 3 weeks. Apart from the physical half-life, which is just a property of the actual isotope itself, we also have to consider what we describe as the biological half-life. So that's slightly more complicated. It depends on how quickly the isotope is actually cleared from the body. So going back to the example of I-131, iodine is excreted by the kidneys. So your kidney function also plays into how long the patient's being exposed for. If your kidney function is not so good, you don't clear the isotope quite so quickly. So as well as the physical half-life, the stuff's just sitting around longer so that the patients can get a higher dose. The half-life also has important implications for radiation protection, so in terms of how long the patient needs to take precautions to avoid exposing other people to the therapy. It also has implications for just getting hold of the stuff and ordering it for treatment. So these are not treatments that we can generally have sitting on the shelf ready to give to patients because they're decaying all the time. So they do have to be ordered in purposely for that particular patient's treatment and usually delivered on the day. And there's a reference activity on a particular day that you then have to calculate from there what the activity that's actually been given to the patient, given the time that's elapsed and the amount of decay that will have happened between the reference time and the actual administration time. So it does make it logistically quite complicated because this stuff has to be shipped on the day of treatment, and a lot of these things come from Europe, so often it's flights and things like that. So occasionally we do run into problems with just the stuff not arriving for various reasons. There's one winter when the stuff was coming through the Channel Tunnel and it got closed due to snow, and we had to put a load of patients off. So it is logistically quite complicated. So I thought it's worth just thinking about what's needed to safely deliver these sorts of treatment. So it's important to have a really well-functioning multidisciplinary team, as really with any sort of cancer treatment. So the key members of the team are, first of all, a clinician who has expertise in managing the condition. So in Sheffield, that's me as a clinical oncologist. Some other centres have specialists called nuclear medicine physicians who are especially trained, and they're trained to give radioisotope therapies essentially on their own. It's also important to have physics expert input to give advice about sort of radiation protection issues and just the technicalities of delivering the treatment. And then we have a team of nuclear medicine technologists who are the people who actually look after the patient and get the stuff in and do the monitoring afterwards. It may also be necessary to have the help of an interventional radiologist. So I mentioned some of the treatments given selectively into a particular part of the body, so that means putting a vascular catheter into the appropriate artery to administer the treatment that way. So we're very fortunate in Sheffield to have the help of an interventional radiologist who has an interest in these sort of treatments, who helps us where that's necessary. You need to have adequate facilities to be able to safely handle the isotope. So that means having special lead-lined safes where they can be stored if they are delivered a day or so early. We have a fume cupboard because when you open the packaging with these things, often they do. There's an accumulation of sort of radioactive gases that have been created from the decay process, and you need somewhere where they can be safely dealt with without the staff inhaling them, which would not be good. So we actually had a refurb of our facilities at Weston Park. We've got a nice new isotope therapy suite in Weston Park. It's also important to have special facilities for the patients. So particularly if you're giving a gamma-emitting isotope, the patients have to be an inpatient for a few days because of not exposing other people, and they have to be cared for in a special room that's lead-lined, so they're not to other patients in the building are not being exposed. And also the room has to have dedicated drains. As I said, particularly with iodine treatment, the iodine is excreted in the urine, so everything they pee is radioactive. And what you don't want is to have a blocked drain and then somewhere in the hospital and a load of radioactive urine sitting in the drain, again potentially creating a risk for other patients. So the room that we have has a dedicated drain that just goes straight down into the mains drainage, so we know it's gone and out of the hospital. So there are quite a lot of things that have to be thought about with it. So in Sheffield we only actually have one room that we can give these treatments in, and there really aren't facilities anywhere else in the trust that would be suitable for doing this without a new build. Beyond the facilities, you have to have access to isotopes, and because these are radioactive substances, they are very carefully it's very carefully controlled by the government. You have to have a license that's specific for the location where you're giving the treatment, the individual who's prescribing the treatment, and for the actual specific treatment and its indication. So I have a license, well, I have a number of licenses, but for example, I would have to have a license to give treatment at Weston Park, that it's me that has to be responsible for signing it, and I'd have a separate license for each indication. So I have one for treating thyroid cancer with radioiodine. I have a separate license for using radioiodine to do diagnostic scans, for example. So it is all very carefully controlled for obvious security reasons. And as I was saying earlier, logistically, the isotopes usually have to be delivered on the day that you're going to use them, otherwise they've decayed and are no use. So talked a bit already about radiation protection issues, but you do need to be quite careful with these things, and it depends on the physical characteristics of the particular isotope that you're using, and as we've said, on the type of emissions and the half-life. These issues mean it's really important you counsel the patients before they have the treatment about what precautions they're going to take. So probably the best example of this is in thyroid cancer. Actually, thyroid cancer is quite common in young women, and often women who have young children, and we worry a lot about exposing young children to radiation. So we advise the patients that they can't have close contact with young children for up to a couple of weeks after they've been in for the treatment. So clearly it's no good getting the patient in, giving them the treatment, and then as they go home saying, by the way, you can't be near your toddler for 2 weeks. People obviously need to make arrangements. So a lot of the sort of work up to the treatment is about sussing out what the social circumstances are, how the patient's going to manage that, and keep everybody safe. There's also an important issue with staff training. So the treatment is actually given, as I've said, by our technologists, but obviously the patient's being looked after on a ward with lots of different staff, the nursing staff, healthcare assistants, and just the cleaners, and everybody on the ward needs to know what the issues are, and that they can't just walk into the room where there's a patient who's radioactive. I visited some colleagues in Oxford when we were doing some training to deliver a new treatment a couple of years ago, and they have an issue with all of their cleaning staff. Very few of the cleaning staff speak English. They've got big populations of people from all sorts of different places, and there's a big sign up on the door in about 20 different languages, basically saying, keep out, don't go in. But it's really important that everybody understands that they mustn't go in and expose themselves to risk. So just moving on to talk about some of the clinical applications. So the biggest area, historically what we've done most of, is treating thyroid cancer with radioactive iodine. The reason this was the first treatment and has been so successful is that we're fortunate with thyroid cells. They very specifically take up iodine. They're one of the few cells in the body that have this pump known as the sodium iodide symporter that pumps iodine into them. So really it's the ideal targeted therapy, because if you give a patient iodine, it almost all goes into their thyroid and virtually no other cells will take it up. So you can deliver huge doses of radiation to thyroid cells but spare everything else. So this has been used for more than 60 years now, very successfully. So there are a number of different isotopes that we use for different purposes in thyroid cancer management. So I123 is a pure gamma emitter, and that's quite useful for imaging. So it doesn't really deliver therapy because it doesn't deliver much energy locally. But it does mean if you want to do a scan for example, to detect whether the patient's got metastatic disease anywhere, you can give them an injection of the I123, do a scan a few hours later, and the isotope will have localized to any areas of cancer in the body, and you can detect it with a gamma camera. The isotope we use most commonly is I131. So this is particularly useful because it's a beta and a gamma emitter. It emits both things. Half-life, as I said, is about 8 days. And it can be given orally, so it's very convenient. The patient just swallows a capsule, and that's all there is to it. So the beta particles are what's useful for the therapy, so that delivers the energy, kills the cells. But the gamma emissions are very useful because we can detect them with a gamma camera and see where the stuff's gone. And as I said, this is very widely used for therapy. The other isotope that's coming along is I124, and this is coming along with increasing use of PET, because I124 is actually a positron emitter. So a number of centres in Europe are moving to using this you get better images than you do with I123 scans, better resolution images. So it's another way of imaging for evidence of metastatic disease. So in the UK, we don't yet have a means of sourcing the I124, so it's not something that's being used here yet, but I think it's something we will see coming in. So before patients have their radioiodine treatment, there are a few sort of practical arrangements that we need to sort out. We've already talked about the sort of counselling about radiation protection issues after the treatment, but there's some other things they need to do to prepare for the treatment to make sure it works as well as possible. So one thing is we have to ask the patients to observe a low iodine diet for 2 weeks before they come in, because if you eat a lot of dietary iodine, that competes against the radioactive iodine and can stop it working as well as you'd like. So low iodine diet, essentially it's anything that comes from the sea, so sea salt, sea fish, shellfish, those sorts of things can be quite rich in iodine, so they have to be avoided. The thing that's most problematic for patients is dairy products. Now, I discovered recently why dairy products have iodine in it. It's because when cows are milked, they dip the udders in iodine to disinfect. So that's why dairy products have quite a bit of iodine in them. But that can be quite problematic for patients. You imagine trying to exclude dairy products for 2 weeks is quite tricky. So low iodine diet for 2 weeks. And then we also need to adjust their sort of thyroid hormonal environment. So there's a hormone called thyroid stimulating hormone, which is made by the pituitary and normally stimulates the thyroid to make thyroid hormone. But the TSH drives iodine into thyroid cells, so we need the levels of the TSH to be high. So the way we can achieve that now, we have a recombinant version of this hormone, recombinant human TSH, which we can give as an injection. So the patients come for 2 days before they come in for the treatment to have these injections to get the TSH levels up that then makes the treatment work. So there are a number of reasons why we might give a patient iodine therapy. The majority of patients with thyroid cancer actually have a very good prognosis, and the majority are cured and don't have spread of the cancer. And the reason we give them iodine really is we describe it as a sort of adjuvant therapy to reduce the chance of recurrence in the neck, particularly. So the idea being if there is residual microscopic, so they'll all have had an operation to have the thyroid removed, and then we give iodine treatment. The idea being if there are any cancer cells left, the iodine treatment will mop those up and stop them causing a recurrence. It also gets rid of any residual normal thyroid tissue, because that's also very iodine avid, and that makes it easier to follow the patients up because there's then essentially nothing left where the thyroid was. So then if you do a scan in the future and find something, you know it's something to take seriously. So the majority of patients, it's an adjuvant treatment, and they do very well and they're cured and go on to live a normal life. We have a small minority of patients who do present with metastatic disease that spread most commonly to the lungs or the bones. I'm not sure the slide projects terribly well, but these are gamma camera images, whole body images of a patient. So the stuff you can see on the image this side is actually largely physiological uptake in the stomach and gut and the bladder. So because the iodine is taken up, because it's taken orally, it sort of the residue lines the bowel, so you see a bit of residue in the bowel, and it's excreted by the kidneys, so you see some uptake in the bladder. But if you look on the other side, you can see in the neck there's a great big blob, which is probably normal thyroid remnant, but also in the lung on the patient's right. You can't see terribly well there, not very projected very well, but there are some lung metastases that have taken up iodine. And we know, particularly in young patients with thyroid cancer that spread to the lungs, radioiodine treatment can actually be completely curative, and often these people do go on to live a normal life. So it's a very effective treatment in that situation. So just in terms of recent developments in thyroid cancer, this slide just shows a trial that we participated in Sheffield. So this was a big UK trial, that really the first randomised trial in thyroid cancer management in the UK that was published 2 or 3 years ago now, looking at giving radioiodine ablation therapy a little bit differently. So the study was looking at 2 different things. One was the actual dose of radioiodine that we give, and what the trial showed was that we could actually safely reduce the dose but still have good outcomes. And that's important because there are risks to giving isotope therapies, and one of the risks is actually causing second malignancies. So we know there is a small increased risk of developing another cancer if you give patients these treatments. And that risk does seem to be dose dependent, so the higher dose you give, the more the risk of second cancers. So if we can give a lower dose of iodine, we reduce the long-term risk. And this study showed that we could very safely reduce the dose. The other thing that was testing was the use of this recombinant TSH, which is a new, relatively new technology. In the past, we'd had to take patients off their thyroid hormone replacement therapy for 4 weeks before the treatment, which was pretty miserable. They felt lousy, but that was the alternative way of getting the TSH up. But this study showed that giving recombinant TSH did the same job. The treatment worked as well, but with much better quality of life. So this is really quite a significant move forward in terms of being able to give it as effective treatment, but with a safer, lower dose of iodine and with the recombinant TSH instead of thyroid hormone withdrawal. So moving on to think about some of the other applications, other sort of less common treatments that we give. mlBG is a molecule that's taken up by this relatively rare group of tumours known as neuroendocrine tumours. This molecule, as you see, has an iodine molecule within it, so we can actually manipulate it to put I131 into that, and then that can then be used as a therapy. So the sort of organic bit of the compound targets the radiation to these neuroendocrine tumours, and the iodine delivers some radiation. So the sorts of tumours we sometimes use, these were a group of rare tumours, pheochromocytoma, neuroblastoma. A rare type of thyroid cancer can sometimes be treated, and some neuroendocrine tumours affecting the gut. Before we give this sort of treatment, we tend to do a tracer scan to see whether there's any uptake by this molecule in the particular patient's tumour. So this is an example of a scan. You can see there's a great big blob. So on the right-hand side of the patient, the uptake is actually in the liver, which is just physiological. But you'll see towards the left, there's a very dark black blob, and that's uptake within an adrenal tumour. The other thing to notice on this scan is that the patient's thyroid is lit up in the neck there. And that's because a little bit of free iodine tends to dissociate from the mlBG, and that's taken up by the thyroid. Now that's potentially problematic when we're giving therapy, because you could actually damage the thyroid and make the patient's thyroid not work. So as a safety measure before we give this treatment, we have to give, in complete contrast to what we do for thyroid cancer patients, we actually give patients huge doses of iodine for 2 or 3 days before the treatment to flood the thyroid with normal iodine, so that if there is any free I131, it can't be taken up, and so the thyroid's protected. So in fact, it's the same stuff that's given if there's a nuclear disaster. So for example, after the Japanese nuclear disaster, everybody in the area was given this potassium iodate. And for exactly the same reason, it's to protect their thyroids from the I-131 that can be released in those sort of circumstances. So again, the patients need a bit of careful warning because this stuff is really designed for nuclear disasters. So the packaging is a little bit alarming. The patients just need to be reassured that it is right, that we've given them the right thing, and that it is just part of the safety for their treatment. So these treatments we know can provide, so patients often very symptomatic, sometimes because of the actual mass effect of the tumour, sometimes because these tumours actually produce hormones that can cause very unpleasant symptoms. And we know by giving these treatments we can often reduce the hormone secretion, which often improves the symptoms and helps patients feel much better. Because the tumours are very rare though, there isn't good evidence as to the effect on disease progression and overall survival in the same way that we have for other treatments in other more common cancers. So that's an area that where research is very much needed. This treatment, rather than being given as a tablet, is actually has to be given intravenously. So it's a bit more of a fiddle. I've put this picture up just to show that there's this slightly complicated jig that we have to have. Essentially, the treatment is just given as an infusion, but because it's radioactive, we just have to have a special jig with shielding around the stuff as it's being given, so that people in the room are not being exposed to huge amounts of radiation. So there's a big kit that comes, it's all delivered in with a lead pot that the actual isotope is in, and that gets sucked out through a burette that's all shielded, and then there's just a very short loop of tubing into the patient to actually administer the treatment. Because this is based on I-131, again, it's a gamma emitter, so the patients do have to stay in for up to a week. They're in isolation for that length of time, so it does get a bit tedious for them being stuck in for that length of time with not much contact with other people. So another sort of treatment that we use in neuroendocrine tumours, and probably what's taken over a bit from mlBG, is becoming increasingly used, is what we call radiopeptide therapy. So this takes advantage of the fact that these tumour cells have a cell surface receptor known as a somatostatin receptor, and there are drugs known as somatostatin analogues that specifically target these receptors, which are very specific for these sort of tumour cells. We've developed the ability to be able to label somatostatin analogues with radioactive isotopes to be able to deliver therapy. So there are two isotopes that are most commonly used, yttrium-90 or lutetium-177. And the handy thing about these isotopes is they're pure beta emitters, so they don't emit gamma rays, so they're not so problematic from a radiation protection point of view. So again, before we give this sort of therapy, we do a sort of diagnostic scan to check that there is definitely evidence of uptake in the tumour. This is an example of what we call a SPECT-CT Oxy scan, and basically the hot yellowy white blobs show where there's significant uptake in tumour, so that this scan indicates that the patient would be a suitable candidate to have this sort of treatment. Now typically for these patients we give a course of 3 treatments at 3 monthly intervals, and we have seen impressive results again in terms of symptomatic improvement and shrinkage of the tumours. To date, again, there hasn't been good randomised evidence, but we're very excited. At the end of this month, there's a phase 3 trial being presented at a meeting in Vienna that's a randomised trial of giving this treatment versus the standard treatment, which would be to use a cold, so an unlabelled somatostatin analogue. And this is created, although the data is all confidential at the moment, it's created a lot of excitement. It's being presented at the presidential session of the European Cancer Meeting. We're told it's one of 3 press releases that's going to be made at this conference about major advances in cancer treatment. So it's widely assumed that this is going to be a positive trial, and that will really encourage the use of this treatment, and I think it's something we're going to see much more of. So this is definitely an area of development at the moment. Just in terms of the practicalities, the treatment is given intravenously. We have to give, because this is a peptide, the somatostatin analogue, it can get stuck in the kidneys, and if you've got peptide labeled with radiation stuck in the kidneys, you could deliver quite a high dose of radiation to the kidneys, and that could actually damage the renal function. So to protect the kidneys, we have to give an infusion of amino acids before the treatment. And again, it's similar to the iodine for the thyroid. the amino acids basically flood the kidneys and stop the actual dotatate therapy sticking in the kidneys and causing damage. But because it's a beta emitter, the radiation protection issues are much less stringent, and generally these patients only have to stay in for one night. It's not a very good image here, but this is actually a picture of our team at Weston Park giving the treatment to her. The guy on the bed is actually a member of staff who was demonstrating. This was some publicity material that we did, but just showing that the staff do have to wear protective gear when they're giving the treatment. And you can just about see there's a special sort of syringe driver that's in a lead shielded jig to protect the staff from the treatment while it's being given. So moving on to a completely different area of treatment, so selective internal radioembolisation, or SIRT as it's known, is another emerging and increasing field. So this is where some of the interventional radiology that I mentioned earlier comes in. So this is a method of actually getting internal radiation therapy into the liver. So there are two preparations now, these glass beads that are labelled with yttrium-90 that can be injected directly into the hepatic artery and lodge in tumours in the liver. Now, this takes advantage of the fact that when there are tumours in the liver, there are two blood supplies to the liver. The portal vein takes blood from the gut, and that's really the main blood supply to the liver. And the hepatic artery specifically supplies tumours in the liver. So if you can cannulate the hepatic artery and put treatment into that, it selectively goes into tumours but spares normal liver. So it's a good way of targeting treatment to the tumours. So this is a treatment that's been approved in the UK for use for colorectal cancer that's spread to the liver, and also a rarer sort of tumour called cholangiocarcinoma, which is a tumour arising from the bile ducts, either inside or outside the liver. And we know that the treatment can shrink and control these sorts of tumours very effectively. So the diagram here just illustrates what has to be done. So the interventional radiologists catheterise through an artery in the groin, put a catheter right up the aorta into the hepatic artery, and then they can shoot these beads straight into the liver. So the treatment does need careful workup beforehand. So one of the potential problems is that there can be shunts between the hepatic artery and the lungs, and you don't want that to happen. You don't want to be putting beads into the lungs because you could cause significant damage to the lungs from the radiation. So you have to do an angiogram as a workup procedure and inject some dye so you can see where the stuff's going to go when you inject it into the hepatic artery. And if there is stuff going where you don't want it to go, the radiologist can put coils in to embolise those arteries so that you don't get stuff going into inappropriate places. So you do need somebody with really significant expertise of looking at where the stuff's going and knowing how to deal with problems and nip those out before you give the treatment. But this slide gives just an example of a patient who's had a very good response to this sort of treatment. So the top line of images are the pre-treatment images. You can see there are lots of black holes in the liver, which are liver metastases. And then the bottom images are the same patient after treatment, where you can see really there's been a dramatic response and improvement. So for some patients, these treatments do really give very impressive results and can control disease for long periods of time. Without causing all the side effects that, for example, systemic chemotherapy would cause by getting into the bloodstream and causing all sorts of other side effects. So another very much emerging area at the moment is radium-223 in prostate cancer. So this is on the back of this paper, which was published a couple of years ago now. So radium-223 is an alpha emitter which targets bone. So basically it's a bit like calcium, and is taken up in areas where calcium's taken up. So what this treatment targets bone, it's given intravenously. Because it's an alpha emitter, there are very few, once it's actually in the patient, there are very few radiation protection issues, so it can be given on an outpatient basis, so it's very convenient. Generally, it's very well tolerated. The main problem being that because it targets bone, you can get some bone marrow suppression, so you have to watch the patient's blood counts quite carefully and make sure they're not being affected. But our experience of treating patients with this has been really significant symptomatic benefit. So You hear stories about patients who come in for their first treatment in a wheelchair, not able to walk because of bone pain, and they walk in for the second treatment with just no pain at all and just feeling heaps better. So it really can work spectacularly well. What's beyond the symptom improvement, what was particularly the reason this got published in such a prestigious journal as the New England Journal of Medicine was that in the initial trial, placebo-controlled trial of this treatment, there was actually found to be a survival advantage. So the patients who got the radium-223 actually lived on average 3 months longer than the patients who had placebo. And that's normally for other treatments that we give for bone metastases or prostate cancer, you would expect to see symptom improvement, but not usually an extension in survival. But this treatment is actually modifying the course of disease and making people live longer. So this caused a lot of excitement, and many centres around the country are gearing up to give this treatment. We're giving it in Sheffield at the moment. So finally, just moving on to give you a bit of a flavour for the research that's going on at the moment. So really just to highlight some of the trials that we're running in Sheffield at the moment. So in thyroid cancer, interestingly, what we're looking at really is pulling back on treatment. So this happens in lots of cancers. We establish what effective treatment is and then realise that actually we can probably risk stratify patients better and identify a group of patients who actually have very low risk of problems and who may not need the treatment. So ION is a trial that we're one of the UK centres for that's investigating whether there's a group of low-risk thyroid patients who actually don't need to have radioactive iodine and who we can avoid treatment altogether. So this trial is randomising low-risk patients to either have iodine or not, and then carefully follow them up with regular ultrasound scans to make sure there's no evidence of recurrence, really hoping to show that there is a group of patients that we don't need to give treatment to. And this is important because, as I've said, radioiodine does carry some risk of second malignancy, and we know there's a group of patients who almost certainly they have no risk of dying from their cancer. They go on to live a normal life. So the last thing we want to do is be giving them a second cancer that may prove fatal. So it's really important that we establish whether this treatment is important or not. And in the past, a randomised trial has never been done to establish the role of the treatment. It just came in as an empirical thing that people did. So I think this is a very important study that we're contributing to. In SIRT, there's ongoing research really looking at the combination of this selective internal radiotherapy with chemotherapy. So this is a trial, again, we took part in Sheffield as one of a number of UK centres. So SIRT has predominantly so far been used on its own to treat liver tumours, but this trial, the Foxfire trial, was looking at patients who would ordinarily just be given chemotherapy and randomising some of those people to have a combination of chemotherapy with the SIRT to see if that led to better responses and better control in the liver. So this trial has actually now completed recruitment, but we were awaiting the results, which should be through in the next 6 months or so. So we await that with interest. Radium-223, as I say, I think is a huge growth area because it's not targeting a specific tumour. It's really just targeting bone tumours. So that potentially has applications in lots of different sorts of cancers. So we have trials in breast cancer, for example, where patients often get bone metastases, and other cancers with bone metastases. And also there are trials ongoing at Western Park using the radium-223 in combination with other treatments. So for example, in combination with chemotherapy, to see if using the combined treatments might be better than just having each on their own. So another really important area in molecular radiotherapy is the whole issue of dosimetry. So the way we prescribe these treatments at the moment is we prescribe an administered activity, so that we prescribe an amount of the stuff that the patient takes in. What we know, though, is that the important thing in terms of how well the treatment works is the absorbed dose in the tumour. So what we would prescribe in external beam radiotherapy in grey. So when you're prescribing some external beam, you know from the work the physicists do that you know exactly what dose the actual tumour is going to get. But in molecular radiotherapy, we know the absorbed dose is very variable because it depends on exactly how much of the isotope is taken up by the tumour in an individual patient. So you can give the same activity to two different patients, and the absorbed dose in the tumour can be vastly different by a factor of 100, depending on how much is actually taken up by the tumour. And at the moment, we don't really have a way of recording the absorbed dose, which is ridiculous, really, because that's the likely to be the important measure of efficacy. So some work's been done, for example, in thyroid cancer with metastatic disease to show the absorbed activity in any one lesion can vary between 20 and 300 gray. Now, if you're just giving 20 gray, the likelihood is you're not going to do much good at all. If you're giving 300 gray, the tumour is likely to be completely killed and treated very effectively. So we really need to do better and know what we're giving. The problem is that dosimetry in these situations is much more complicated than it is with an external beam treatment where you switch the treatment on for a defined length of time and you know exactly what's being delivered where. So there are a lot of factors that you have to take into account, and you end up with these complicated equations which I wouldn't pretend to understand. But effectively, the absorbed dose depends on the activity that you administer, the degree of uptake in the particular target lesion, and the half-life, both the physical half-life of the isotope and the biological half-life of the thing in the patient, how quickly the patient gets rid of it. So it's really quite complicated, and you have to take measurements and scans at multiple time points after the treatment to be able to create graphs like this and then back calculate what the absorbed dose is. Now, it is possible, but it's time consuming and it's not something we do routinely at the moment. But as I said, there is a feeling in the UK that this is something important that we do need to get to grips with because, well, first of all, it would allow more accurate documentation of therapy. And in fact, the European regulations about radiation therapy are stipulating that we do need to record absorbed dose when we're giving a radioactive treatment, and we just don't really have a way of doing that with isotope therapies at the moment. So that, if we were able to do that, it would also allow us to better predict the efficacy of the treatment. We would also be able to give safer treatment, because as well as determining the absorbed dose to the actual tumour, we'd be able to determine absorbed dose to other organs, the organs at risk. So, for example, the kidneys and the bone marrow. And also, it would allow us to potentially to individualise treatment. So if we did an uptake scan first, work out what dose was delivered to the target organ, you could then back calculate to work out what activity you need to administer to deliver the dose that you actually want to get to the organ, rather than just giving an empirical dose as we do at the moment and hoping for the best. So there are important reasons why we need to do this. So that leads me on to a study that I'm involved with at the moment with a group of thyroid oncologists around the UK, particularly looking at this group of patients, a small subgroup of patients who have what we call radioiodine refractory thyroid cancer. So as I said, the majority of thyroid patients actually have a very good prognosis and are cured by a combination of surgery, radioiodine therapy. But about 5 to 10% of patients develop advanced disease that becomes resistant to radioiodine. So either they don't take up iodine to start with, or they do initially respond to the iodine therapy and then become resistant. And we know for this group of patients, the prognosis is very poor. Median survival is 2 or 3 years. And until recently, there have been really very few existing treatment options. So they just got really supportive care. So we know that the reason these patients become iodine resistant is to do with changes in molecular signalling pathways, and particularly what's called the MAP kinase pathway on the left here. And we know activation of that pathway by mutations in tumours switches off the expression of the sodium iodide symporter, so that means thyroid cells can no longer take up iodine. But what we found in sort of laboratory work and cell cultures is that by inhibiting that pathway, using inhibitors of one of the bits of the pathway that we call MEK, you can actually switch back on expression of the sodium iodide symporter. So in cells that have become resistant, you can make them sensitive to iodine again by switching back on expression of the sodium iodide pump. So one example of these MEK inhibitors is this drug called selumetinib. And there's some preclinical work has shown that it can, in cells that have previously become iodine resistant, selumetinib can help them take up iodine again. And a pilot study was done at Memorial Sloan Kettering in the States, giving patients 4 weeks of selumetinib. And there were only 20 patients in this study, but 12 of them actually had evidence of significant increases in iodine uptake after just 4 weeks of this therapy. And several of those patients then went on to have further iodine therapy, having become resistant to the iodine therapy, and seemed to get clinical benefit from further iodine. So this is very exciting. It means patients who had got to the point where they could no longer benefit from iodine can have more iodine therapy, potentially with more clinical benefit. So this is just an example of some images from the pilot study. So the image on the left is the pre-selumetinib scan, and essentially what you can see there is just physiological uptake of the iodine in the gut. There's no evidence of uptake in metastatic disease. The patient had 4 weeks of the selumetinib and then was re-scanned, and you can see on the repeat scan there's evidence of good uptake in several lung metastases and probably in some nodal disease in the neck as well. So that's really quite an impressive change from absolutely nothing to really quite good uptake in the metastatic lesions. In the UK we're developing a trial at the moment, which I'm actually leading on, in a number of centres around the UK, called the Dosimetry trial. So this is really trying to replicate the findings of this pilot study and demonstrate that the technique is feasible in a multi-centre setting. So there are 8 UK sites taking part. And look at with more of a focus on clinical outcomes. So basically what the pilot study showed was that you see increased iodine uptake. It didn't really measure the effect of that on clinical outcomes. So our study is going to be a bigger study looking at more patients and investigating the effect on progression-free survival. And as part of the study, we're also going to do some work on this business of lesional dosimetry, trying to work out what absorbed dose is going into these lesions to look to see whether we can better individualise treatment for those patients. And also looking at whether there are any molecular biomarkers that might predict for benefit from this drug. So there are particular mutations that we know can be present in thyroid cancer cells, and we want to see whether having one of these mutations makes you more or less likely to benefit from the selumetinib drug. So just to summarise, there's been a significant increase in applications in molecular radiotherapy recently. To give these treatments, you need a well-functioning multidisciplinary team, and you need to have appropriate facilities. There's lots of research going on at the moment, and probably the key areas, I think the most important areas, are looking at better dosimetry and individualising, personalising treatment for patients, and then also looking at combination of using molecular radiotherapy alongside other therapies, chemotherapy, targeted agents, those sorts of things. So that is very problematic. So in the order of several thousands of pounds a shot. And that is problematic at the moment. So we have been able to access them via the Cancer Drugs Fund, which is a facility to fund very expensive new cancer therapies. Unfortunately, last Friday, the Cancer Drugs Fund published their latest review, which has said that the radium-223 for prostate cancer and the peptide receptor radiotherapy are going to come off the list. Hopefully, NICE are also looking at them and doing appraisals for both at the moment, and we're expecting, because the results have been so positive, we're hoping that NICE will say they are actually cost effective and will fund them. But yes, so it's tens of thousands of pounds per treatment. The advantage of them, though, is that it is a short course of 2 or 3 treatments in most cases, rather than chemotherapy, where the cost can be several thousands of pounds a course, and you just go on giving it and giving it and giving it, so you can run up hundreds of £1,000s in a year. So although each individual treatment is quite expensive, each patient only gets 2 or 3 treatments generally.
This new trial that you just started, which looks really, really exciting, what is it starting now? Is it something
So we're hoping to, it's going to, the protocol, it's all been funded, the protocol is imminently going to be submitted to ethics, and we're hoping to be starting recruitment by the end of the year. Yeah, so it's sort of, so frustratingly, no, because we don't quite have the facilities to be able to do it. So although I'm the chief investigator, I'm not actually, so we'll be but Sheffield patients will be able to access the trial because the Christie are acting as a site and have agreed to take patients for us. So yeah, so.
I had one on imaging. I was at Peter Marker a few years ago in Melbourne, and there those somatostatin receptors, as well as the treatment
Yeah.
PET scan, basically, then you see the dosimetry. But the images you got of where the uptake was were amazing.
Yeah, so gallium dotatate PET is definitely the way forward. So we're working on hoping to be able to access that in Sheffield. At the moment, the Christie are doing it, and in fact, we often send patients over there because you get the images are so much better. What we use for a tracer scan at the moment is indium 111, and the images are nowhere near as good as you get with the gallium dotatate PET. Certainly, yeah. So yeah, I think the image that I showed might have been a gallium PET actually. The image I showed earlier, but yeah, you do get much better resolution with the PET.
I'd like to ask you mentioned on one of the slides about counselling patients that are going to have young patients with radioiodine with cancer. We also do a lot of radioiodine for the benign conditions.
Yeah.
How does the counselling differ, I suppose?
So from the radiation protection point of view, it's actually, in many ways, it's very similar because it's exactly the same isotope is being given, exactly the same sort of issues in terms of protection of children. So for benign disease, if you give a young woman iodine, then they have to usually be out of the home for a couple of weeks afterwards. I guess the big thing that makes a difference is a patient's been labelled with cancer. There's just all sort of overlay, which just makes it additionally upsetting. And something I've done a lot of thinking about is the trouble is with papillary thyroid cancer, which is the thyroid cancer that affects most of these women. We know the prognosis is excellent, so the 10-year survival rates are over 99%. So basically, these patients don't die of this cancer. But it's actually very difficult communicating that with patients. We went to a very interesting talk given by a psychologist from the Marsden earlier in the year, who said that she'd had patients say that one thing they've really struggled with, that they're told that they have cancer, which obviously is absolutely devastating to be told when you're in your 30s. But then everybody almost belittles it by saying, oh, but it's not really cancer and you'll be okay. And you tread a really fine line with these people between being sympathetic to the fact that they've had a life-changing condition, but reassuring them that it's going to be okay and almost certainly they will live a normal life. So it's something that you have to give a lot of thought to, actually. And interested. So the other bit of my practice is upper GI cancer and pancreatic cancer and misery, where people all die very quickly. But I actually find I have far more tears from the thyroid patients, partly because they're young and they've got young children and young family, and the radiation protection issues are very difficult. If you've got a 2-year-old, you've been told you've got cancer, you're going to be shut away in a room and then not be able to see your children for 2 weeks. It's just awful. So I get far more tears from that often than I do from patients who are dying from pancreatic cancer. So you do have to think about it very carefully. We're very fortunate we've got an excellent team of specialist nurses and also the nuclear medicine technologists are very skilled and very experienced at handling these patients and are very good at giving them as much information as possible and helping them sort out things for at home.
So if somebody's had all the information about radioiodine for benign treatment, do you get many people saying they've changed their mind and they don't want it?
Yeah, so in benign disease there often is a choice. Often you could have an operation to have the thyroid removed. And yes, some people just can't accept the issues in terms of being separated from children. For that reason would opt for an operation instead, yeah.
Well, thank you very much.